So my name is Kelly, and today I'm going to discuss admission forms here at Austin Veterinary Emergency and Specialty Hospital. What I'm going to discuss with you today, I'm using a dentistry and oral surgery admission form. The first step here is we have the presenting complaint, which is why we are seeing your pet for a dental cleaning. Asks, how was this problem noticed? For this particular dog, the 7-year-old Rottweiler, they could just see visible plaque. There was not actually any no issues like not eating, facial swelling, drooling, anything like that. This is just a routine dental cleaning. So on this, the first form that we have filled out with the client is patient history. Talks about presenting complaints, what are the symptoms, how long have the symptoms been there, just talks about diet and appetite. Has your pet's appetite changed recently? For this patient, no, it has not. Any trouble eating or drinking? Explain that, please. What type of food do they eat, and if they're on a special diet. Down here, dental history. This is just asking if they've ever had a cleaning before. This pet had back in 2016. On the back of this form is a little more questions. It asks what kind of dental home care do you provide. They said there's toothbrushing once or twice a week. Any toys or bones that they use are Nyla bones. And then it asks a little bit about medical history. Asks if the pet has any health problems. This particular person, this pet does not have any health problems, but that would be very significant because if there were things like heart disease, liver or kidney disease, those things would affect the anesthetic protocol and possibly whether we would even do the procedure at all. So those things are very important to find out. The next question is asking to list all medications. This is very important because some medications can affect anesthetics or the adjuncts. For example, some antihistamines, they can exacerbate central nervous system responses and cause respiratory depression. So that is why it's a good idea to know what medications the patient is on. Is the pet currently taking any meds? What are the medications? Have the medications been associated with any improvement in the condition? Let's see here. Asks about previous surgical experiences. Has your pet had anything done other than spay or neuter? In this case, no. Any drug allergies? That is very important to find out because depending on what the allergy reaction was, that may determine what drugs we may or may not use with this individual. Are pet's vaccines current? This pet, yes. That is important because some hospitals do not allow hospitalization of patients if they are not current on their vaccines. And then, okay, so that is going over the patient history form for a dental and oral surgery admission. So my patient here that we're using today is Maya. She's a 7-year-old spayed female Rottweiler, color black and tan. So some things, the signalment, so the breed is important to know because some breeds react differently to different anesthetic agents and adjuncts. Age is very important. Very, very young animals like neonates and then geriatric animals, they react differently to anesthetics and anesthetic agents. Sometimes, for example, with geriatrics, you might not use as large of a dose as you normally would with a younger patient. Okay, so the sex and reproductive status is very important to know because depending on the pregnancy status would determine what anesthetics we use. Species is important because different species react differently to medications. So what works for a canine may not work for a ruminant. And then different breeds have different anatomy, and different breeds have different anatomy and physiology and respond differently to anesthetic agents as well. So that covers the signalment, species, breed, age, sex, and reproductive status. And okay, so that is the patient history form for a dentistry and oral surgery admission. Okay, the other form that we use is the actual patient admission information sheet. So this is what we would go over with the owners when they come to drop the pet off. So what this is we would have the patient signalment and their sticker up here, time of the last meal, today's contact numbers. Very important to have this because if we call them, we really need to get a hold of them, and we need to convey that to the owners so that they understand that. It goes on to say most patients are able to go home same day as procedure, but sometimes we do need to hospitalize them overnight. This goes over, again, we discuss current medications, type of medication, and dose, frequency, and the last dose given. Again, we talk about is your pet on a special diet, and any changes in the patient's medical condition since we spoke to them and got the patient history at the previous visit. Okay, so that is the patient admission form and patient history paperwork. Okay, so what I'm doing here is I'm showing the permanent patient records. So here I am in Remus's chart. Remus is the patient name there. And so for the permanent patient records, for example, say they are coming in as a transfer from another clinic. So I go into medical notes, and then you'll see RDVM Rex, which is regular DVM. So you'll double click on that, and then it brings you to this page. You'll go to attachments, and then double click there, and you can kind of scroll through. And so this is like the records they came over with, the records that were sent here. Otherwise, all of the records here, you can scroll through in summary, and it will show you everything that we've done. Problems, that one's empty. Okay, prescriptions here will show you what medications have been prescribed here at the hospital. Medical notes. We'll have like the referral letter, discharge summary. This dog actually was here yesterday, went back to the RDVM today, and then came back tonight for monitoring. There's a lab button here as well, and this is where we have all of the lab work that we've done for this patient.
Oh, cool.
And if you double click on it, you can get another detailed version here, and then this one you can actually print also if you need to. Okay, so that is how we keep all of the lab forms for each patient. And if they were brought in as an attachment, it would be in the medical notes with like the RDVM recs. Okay. Okay, so this is part 1.3, the release and consent forms. So what we have here at our hospital is we have what we call the yellow sheet, and on this form, this is where we go over all of the information with the risks associated with anesthesia and surgery. We talk about potential side effects, the risks and the benefits, so the owners know everything up front and know what they're signing off on. On this first section here, we discuss whether or not they want cardiopulmonary resuscitation. I would go into what it means to sign for a DNR, or do not resuscitate, which means that we would not administer any cardiopulmonary resuscitation. I would go over with the owner what CPR entails, and what that entails is we would do chest compressions, we intubate the patient, and then we breathe for them, and we do this until we can get a heartbeat or until we get them to breathe again. We go in what is called 3 cycles, so it would be 3 sets of 2 minutes. So every 2 minutes, we would listen and try to determine if there was a heart rate or if they were breathing. Throughout this whole procedure, we have them connected to an ECG, and we are placing an IV catheter so we can give medications such as atropine and epinephrine to help get the heart started. So that is what CPR entails, and yes, it is about $300 for us to do this. OC CPR is open chest CPR, and we only do this for patients that are in surgery. So if you are done with surgery, you're in the ICU, we would not do open chest CPR. If you are in surgery, then yes, if the owners did want it, we would do open chest CPR, which means that we would physically cut into their chest and manually massage their heart to stimulate CPR. So then what this is saying is just says that the owner authorizes treatment, anesthesia, and surgery to be performed on my pet. I have been informed of all possible complications and the anticipated prognosis. If they accept these risks, then they will sign here. On the second part here, we have this is the estimate version. So for this particular patient, for this dental, they're estimating a $2,000 bill in the end. And what we require is 75% deposit today for that procedure. So for this particular patient, it would be $1,500, and that would be due today. And here on this bottom, this just signing here means that they understand that services, that if further services are required, that they are expected to pay the rest of the bill. And it talks about how we give them a full copy of this and a copy of the estimate for their records. So that is what we would do to get the release and consent forms signed. On top of this, I would discuss with them what the dental procedure is, meaning we would anesthetize them, we would intubate them. So we have them on a machine. They do breathe on their own. However, if they need assistance, we can hook them up to ventilation. We have an IV catheter in. We are giving fluids throughout the procedure to keep the cardiac output up. For the cleaning, we do a scaling, an ultrasonic scaler, and then we polish, and then the doctor will come through and do, she will chart the mouth, and if we need to do any extractions, maybe there's some gum pocketing, we need to put some doxyrubicin in there, all of those types of things. That is the procedure that we do the dentals in. Afterwards, as soon as it's done, the doctor does call you, the patient or the client, and then you guys can discuss how the procedure went and when to pick the patient up. Generally speaking, it is that same day, but occasionally we do need to keep patients overnight just for a little extra monitoring post-anesthesia. Okay, so that is how we go over an authorization and release form for a dentistry patient. Okay, so this is video part 1.4. This is discussing cage cards and other forms of identification. So what we have here, these are our cage cards. It has patient name, age, sex, breed, the diagnosis, and the department and the doctor. So for this particular patient, she's kind of grumpy, so we do have a caution tag on here. Also, the department, we will have whether it's emergency, this is dentistry, internal medicine, oncology, everybody has their own cards here. Now, when we're picking up the patient to then go take him to the procedure, we compare the cage card to our SmartFlow system. So this is Winnie. So I would click on Winnie, and then I can see here canine Chihuahua, weight, problem list, and owner, first name and last name, and usually we have a telephone on here as well. So we would compare that to our authorization and release forms to ensure that we have the correct patient. Okay. So this is for section 1.6. This is the anesthesia forms. So we use a program called Animal Intelligence. So here I am in Gizmo's record. Gizmo is a Yorkshire Terrier, last name Lopez. So this is an example of how our system works. So he had a dental on January 11th. The anesthetic record. Okay, here's the flow sheet. They're all in PDFs, so I have to double click on it. And this is what the flow sheet looks like for the procedure. So it has everything, you know, your weights, temps, heart rates, pulse quality, respirations, character, mucous membrane colors, and it has everything and all of the medications here as well. And so it has what times and who did these things. So that is the flow sheet for anesthesia. For the anesthetic records, this is another part of the system. This is the anesthetic flow sheet. So this is telling you what procedure they're here for, their weight, their dosing weight. We have temperatures, heart rates, respirations rate. We have blood pressures. We have the procedure, the pre-medications, the induction medications. Okay, and so then here is yet another PDF, how we plug it into our system. Okay, so here it prints it out in another form saying these are the pre-meds, that's the induction, what were the vital signs. Here's the anesthetic plan. And then it goes on to record exactly what time and what we did things. So all of these things are then plugged into our animal intelligence system in PDFs. So that is how we keep anesthetic flow sheets in our system. Hi, so today I'm going to discuss discharge instructions. when I discharge patients, I work in the EC, but a lot of times we will discharge surgery patients or dentistry patients. And when we do discharge, we have our little, and I'll videotape this so you can see it a little closer. So what we do is we just kind of go over the entire thing, and we read it along with the patient, pointing so they can read along too. And then we stress that when they go home and their brain is a little bit calmer, to reread through everything again, and then call if they have any questions. So the discharge instructions I'm going to go over for the video are for a laparoscopic ovariectomy and a lap-assisted gastropexy. So this particular patient, her surgery went very well. Hopefully the prophylactic gastropexy will prevent any GDV in the future, and the ovaries were removed as well. So the instructions to the owner are for exercise restriction until her incision heals. She should be kept as calm as possible, no running, jumping, roughhousing, and definitely keep on a leash for at least the first week, if not going into the second week. Limit her walks to 5 minutes, which is basically just enough time to go potty and then come right back in. So we're just stressing not to put too much stress on her sutures or incisions, so everything heals properly. For diet, continue normal diet for the next 5 to 7 days. Offer her about a quarter of the amount of her food, and do so. Offer about a quarter of the amount of food, but feed her 4 times a day. Again, so we can ensure that her incisions heal properly. For the incision, we say ice the incision for 10 minutes, 3 to 4 times a day for the next 2 to 3 days, for the first 2 to 3 days after surgery. This helps with healing and minimizes inflammation. We want the owners to check the incision daily, looking for any redness, swelling, discharge, or dehiscence where the incision actually breaks open. We definitely want to discourage licking or chewing. We always send our patients home with an e-collar to prevent that. And then we really stress that they need to leave the e-collar on until the recheck in 10 to 14 days. Let's see here. All right, so here it talks about the e-collar that I just talked about. We want them to call if the patient appears depressed or lethargic, if her incision appears infected, if she stops eating or seems uncomfortable or in pain, or if she has any GI upset, which could possibly be from the carprofen that we would send home, and I will go over that in just a minute. So additional instructions, we just kind of go over what the laparoscopic ovariectomy and gastropexy procedures are, and we don't expect any complications, but leaving parts of the reproductive tract in the body, there is a very rare chance of getting cancer, but like I said, that's pretty rare, and discuss the possibility of having to go in and remove those parts, as well as the gastropexy. It's prophylactic, but it is not guaranteed that this dog will not get a GDV at some point. Let's see here. So it says, we already talked about the exercise. It kind of goes over things several times on our discharge instructions. So the medications to go home, we're sending home carprofen 100 milligram tablets. We are instructing them to give 1 tablet with food every 12 hours for 14 days. we are saying start this medication the next day at 7 a.m. This goes on to discuss that carprofen is an anti-inflammatory and an analgesic, but it is a non-steroidal anti-inflammatory drug, and they're very effective in reducing pain, inflammation, and fever. However, GI upset can occur, so we encourage them to watch for vomiting, diarrhea, lethargy, and black tarry stools is definitely one thing we tell the owners to look out for. If they see any of these issues, they should stop the medication and call us. The other medication going home for this patient is gabapentin. Because of the size of the dog, we were giving 300 milligram tablets and 100 milligram, capsules. So we want them to give one 300 milligram and one 100 milligram every 12 hours until the prescription is gone. So again, start the med tomorrow at 7 a.m. And this kind of goes on to say gabapentin is used to treat chronic pain in both cats and dogs, particularly neuropathic pain, and it's also used in arthritic pain and pain associated with malignancy. The most common side effects with gabapentin are mild sedation, and if that is noted, we recommend that they give us a call. And then finally, we recommend for this particular patient in this procedure for them to return in 14 days for a recheck. There we will check the incisions and get a short history from the owner and find out how it's been going the last 2 weeks since the surgery. So that is how we would go over discharge instructions with the owners. Again, this was a surgery discharge for a laparoscopic ovariectomy and a laparoscopic assisted gastropexy. Okay, so this is just a little video of just kind of going over our discharge instructions so you can see them. Okay, so today I'm going to show you how to hold for blood draws. So for the cephalic, what you would do is you would extend the arm out and you grab on the inside and roll it out so the vein kind of rolls to the top of the arm here and is easy to access. For jugular, what you would do is either take off the collar or move it out of the way. You would extend the neck up like this so the blood drawer has access to both sides. And then for the saphenous vein, how you would, hold on Bubba, come here sweetie. Okay, so how you would for the saphenous vein lateral is right here. So you would hold off a little bit above the knee, so then the vein will pop up. So you hold it just like this, and then the person has clear access to the vein. So today what I'm going to do is apply this muzzle to this dog. So you want to kind of make sure that the circumference is similar to the dog's muzzle. And so what you're going to do is you're going to kind of come up behind them, scoop it on, and then you're going to fasten it behind the ears like that, and you want it to be tight so that way it's safe to perform things on the animals.
Okay, so today I'm going to show you how to fit an e-collar on a dog. So what you want to do is you want to have it unfolded like this. You're going to kind of go down and you want to wrap it around their neck and you will fit it. You can kind of figure out which notches that you want to use, and you want to make sure that the dog's muzzle doesn't go past the outside. Otherwise it defeats the purpose of the cone. Okay, so you can stop it and then I'm going to put it together. Okay, so on my previous video I showed you how to measure for an e-collar. So once you appropriately measure the e-collar and then put it together, all you do is slide it over the head. So you'll just slide it on, make sure it goes over the ears, and then you will tie it. We use a little bit of bandage material, and then again, same thing, just to take it off, just untie it and pull it over the head. And that is how you fit and put on an e-collar. Okay. Alright, so I'm going to draw blood from the jugular vein here. Patrick is holding the head up in an extended position. I'm going to put my thumb on the thoracic inlet on the left side, and I'm going to feel for the jugular vein. I'm going to put a little bit of alcohol on it. I've got my 3 ml syringe here with a 22 gauge needle. Alright, hold still, Bubba. I'm going to bevel up at a little bit of an angle. Oh, you're wiggly. Hold on, Bub. We're in.
Stay.
Hold on. Okay, so we just finished drawing the blood. I got about 2 mils and put it in the lavender top tube. Patrick is holding off on the neck for a good 30 seconds to make sure that we don't have a hematoma. But otherwise, he did great. Thank you. All right, so Colleen is occluding. We're doing the medial saphenous. Okay. Okay, so I put the alcohol on. She's occluding the vein. I'm going to go in, bevel up, and we're just getting enough blood for a blood sugar. I'm right in it. All right, I've got enough. Got a flash in there. Okay, and then I'm going to place a Band-Aid on and we'll remove it in 30 minutes. Awesome, thank you. Okay, so I'm going to draw blood from this dog's lateral saphenous vein. I've got my gloves. I've got my alcohol. I've got my Band-Aid. I am going to shave just a little bit over this vein just so I make sure that it's a good stick. Okay, so as you can see, maybe, there's the vein. Yeah, you can see the vein very easily right there. Okay, so I'm going to use this butterfly catheter. We're drawing for coagulation tests. All right, so I'm going to put in my catheter. It's a 21 gauge butterfly. I'm going to go bevel up. Hold on, Bubba. Hold on, hold on. Good boy. Okay. All right, so I'm going to try to draw at least 2 milliliters because I need that for the blue top tube. Oh, wait, here we go, here we go.
Yep, perfect.
Awesome. There we go. Okay. Okay, pull the needle out, put my Band-Aid on. This needs to stay on for at least 30 minutes to help it clot. And that is how you draw for coagulation times using the lateral saphenous vein.
Okay, today I'm going to discuss the minimum database, which includes the packed cell volume, the total solids or total proteins, blood glucose, blood urea nitrogen, and alanine aminotransferase or ALT. These tests are just a starting point as a pre-anesthetic workup, and depending on the results of these tests, it may indicate the need for further diagnostics. So with the packed cell volume or PCV, what that is it measures the percent of whole blood made up of red blood cells. So a decreased PCV is found in cases of decreased production of red blood cells, decreased lifespan, such as with autoimmune diseases, and RBC loss, for example, with trauma or blood clotting disorders. Anemia is very important to diagnose because it is directly related to the capacity of the body to deliver oxygen to tissues. Increased PCV may indicate dehydration or absolute polycythemia. Any numbers that are found outside of the normal range should be reported to the doctor. Normal ranges for dogs is 37% to 54%. Cats is 27% to 48%. The total solids or total proteins gives us information about the animal's plasma levels of specific proteins. In particular, the three most important ones are albumin, fibrinogen, and globulin. Changes in the patient's serum oncotic pressure is directly related to the fluid shifts in the patient's body. For example, from the interstitium to the vasculature. With low serum oncotic pressure, fluids tend to remain in the interstitium instead of the vasculature, resulting in edema. High serum oncotic pressure results in the shift of fluids from the interstitium to the vasculature. Elevated serum proteins are associated with dehydration, malignancies, and infection. Decreased plasma proteins are associated with inadequate production. For example, albumin is made in the liver. Inadequate intake, such as starvation, and increased loss like renal disease and blood loss. You can also have inadequate absorption from the GI tract, like with IBD and pancreatic disease. Plasma protein levels are important because some anesthetics like barbiturates are highly protein bound. So if a patient is hypoproteinemic, then more free drug circulates in the system, meaning free, not bound to proteins, which effectively increases the dose of anesthesia. So the patient's protein levels are very important because it may cause the anesthetics to be used, the doses to be adjusted according to the protein level. Normal range of total proteins in dogs is 5.5 to 7.5 grams per deciliter. In cats, the normal protein level is 6.5 to 8.2 grams per deciliter. Blood glucose indicates carbohydrate metabolism and the endocrine function of the pancreas. Eating increases blood glucose and fasting decreases it. Stress can even increase blood glucose in cats. In juveniles and diabetic patients, the blood glucose should be checked preoperatively, intraoperatively, and even postoperatively if the procedure is particularly long. Normal range in blood glucose in dogs is 80 to 130, and normal blood glucose in cats is 70 to 180. Anything less than 40 is considered hypoglycemia, but if you get anything outside of those ranges, it should be reported to the doctor. So with blood urea nitrogen, or BUN, urea is a nitrogenous waste compound that is a product of amino acid breakdown in the liver. BUN levels allow us to evaluate the kidney's ability to remove the waste from the body. So if the kidneys are not functioning properly, that means that they are not eliminating enough urea from the plasma. So that would indicate an increased BUN. The BUN is very important because a lot of anesthetics are excreted or metabolized from the body through the kidneys. So if the BUN is elevated, that's important because you may end up using an anesthetic that is not primarily excreted through the kidneys. The normal range for both dogs and cats is 5 to 35 milligrams per deciliter. Alanine aminotransferase, or ALT, is found primarily in liver cells. So if there is damage to the liver, then that would result in an increased ALT. Some drugs like anticonvulsants and steroids can actually increase ALT levels, so it's really important to find out what medications patients are taking prior to undergoing anesthesia. Normal range for dogs is 8.2 to 109, and cats is 25 to 97. So for this discussion, I will be discussing needed additional databases or tests that might be required if you were to find abnormalities on the physical exam, such as geriatric, sick, or injured patients. So in geriatric patients, disease processes more commonly occur, such as organ failure, cognitive dysfunction, seizures, cancer, and arthritis. So an additional database test for them would be a complete blood count. It would show us hydration status, anemia, blood clotting abilities, and infection or immune status function. A blood chemistry test would show us liver and kidney function and electrolytes and metabolites. A urinalysis would also be good to run because it allows us to see the function of the electrolyte and water balance. It affects blood pressure and elimination of many anesthetics. In sick and injured patients, a complete blood count would be important to do because it allows us to see if there is any anemia, and that is very important with the anesthetic patients because it decreases the ability of oxygen to reach all of the tissues. Evaluation of white blood cells would be important because it gives us any clues into any infections, toxicities, or even leukemias. Platelet counts and coagulation tests are important because it would give us a clue as to the possibility of having any intraoperative or postoperative bleeding after the procedure. With sick and injured patients, a urinalysis would be important also because it gives us information on the kidney and liver function. Blood chemistry tests assess organ function. Electrocardiograms a lot of times are important because it gives us information on the rhythm and function of the heart. And EKGs are also recommended for patients with already known heart dysfunction or failure. Electrocardiograms are also important in cases like GDVs or maybe splenic problems. We do an EKG on those patients as well. X-rays are also very important for patients that come in with dyspnea or pleural effusion, any major trauma like being hit by a car or dog fights, and they're also very important for patients with cancer to check for metastatic disease. MRIs and CT scans
are important for those patients that come in showing any neurologic deficits. Sometimes patients coming in with seizures, we would like to do an MRI or CT on, because that would give us information as to the cause of what is going on. And ultrasounds are another important tool. We perform those for lots of reasons. A lot of times, something as simple as several days of nausea and inappetence, vomiting. We will like to do ultrasounds on those animals to see if we can get a picture as to what is going on internally. So this is what the drug log looks like. This is buprenorphine, 0.3 mg per mil. So today is the 28th. Patient's name is Sunny Taylor. It was for pre-med, and the amount was 0.015. So subtracting this amount from the balance on hand equals 14.075, and there are my initials. And that is how you fill out a controlled drug log after you use a medication. Okay, so today I'm going to be going over the parts and functions of the anesthesia machine. So first and foremost, you can see here our green tubing. This is the oxygen source. So we have our oxygen tanks. They're size H tanks, and they are in another room in the hospital that I will show you here in just a little bit. So we, all throughout the hospital, we have several different anesthesia machines, and we have the oxygen cables and the scavenger, the pink tube, our scavenger system cables, hanging down from the ceiling and all over the hospital. So first and foremost, we've got the oxygen. The oxygen comes in our intermediate tubing, and it comes into the, you can kind of see here, it comes into the bottom of the flow meter. And the flow meter is what we adjust so we can determine the liters per minute of oxygen flow. So the oxygen enters here, the little knob on the bottom. You turn to the left to turn the oxygen on. To read it, you would read right at the center of the ball. So I've got it here set on 2 liters per minute. The oxygen enters the flow meter, the knob on the bottom adjusts the rate, and then it comes into this tubing here. The oxygen leaves the top of the flow meter, and it comes in and goes into the vaporizer. Now on the flow meter, when you turn it off, it's when you turn to the right to turn it off, you want to be real delicate about it, because if you turn it too hard, it will break the stem inside the system. So basically, you just want to turn it until the ball gets down to 0 liters per minute. So then leaving the flow meter, it goes right next door to the oxygen flush valve, which is this little button down here. The oxygen flush valve rapidly delivers large volumes of oxygen to the patient, and it is pure oxygen. It bypasses the vaporizer, so there's no anesthetic being pumped through when you hit this the flush valve. The flush valve feature is used to rapidly inflate a reservoir bag, or to get oxygen to a critical patient very quickly. The flow rate of this flush valve is approximately anywhere between 35 and 75 liters per minute. So it is quite a bit stronger than what we can use with our flow meter. So you need to be very careful when you're using that, because you can damage the patient's lungs. When using the flush valve, when you use it, you want to, because of the strength of the oxygen coming through, you want to use it in short little bursts. Again, that will help keep your patient safe. And when you are pressuring it, this manometer here, this is the manometer, and this will tell you the centimeters per H2O of the pressure. So, okay, the other reason you would use the oxygen flush valve, for example, is at the end of your procedure and you're trying to get all of the anesthetic gas out of the breathing system here and just give the patient fresh oxygen. So what you would do is you would disconnect your rebreathing tube and plug the bottom of the tube here. You would fill up the oxygen bag, the reservoir bag, and then you would squeeze it to get all that anesthetic air out of there. And normally we do it like 3 to 4 times. And then that way, and then hook our patient back up, and that way we know that all the anesthetic is out of the system and we're just giving them fresh oxygen. And you would never want to use the oxygen flush valve when you're using a non-rebreathing system, because it could really damage the patient's lungs. Okay, so after the oxygen goes through the flow meter, it goes next to the vaporizer through the inlet port, which is right here, and then into the vaporizer. This is a precision vaporizer, and it is only to be used with isoflurane. Here is the little window that tells you what the level of isoflurane is in here. It needs to be between the two white lines, and it's about 3/4 the way up. And to refill it, you would take this little screw top off and pour the isoflurane in there. So the function of the vaporizer is to convert liquid anesthetic to a gas state, so then the patient can inhale it. And the reason it's called a precision vaporizer is because it allows us to choose exactly what rate we want this at. And to turn this on, you would press the little black button here on the left and then turn it to your desired rate. It's 0.51, 1.52, and you can even go in between those dashes, so you can really kind of control the rate of flow. Okay, and the vaporizer inlet port is this tubing right here, and it comes into the vaporizer. And then the outlet port is this tubing that comes right here, and this is where the anesthetic gas exit. It exits the vaporizer, comes around here, comes around to the front here, and goes into the inhalation port, unidirectional valve. So this is our rebreathing. This is one of our rebreathing systems. So how this works is the inspiratory valve here goes into the inspiratory inhalation unidirectional valve. And so it takes that anesthetic gas, the fresh gas, and this is where the patient breathes in that fresh gas. As the patient exhales, it comes back through here and goes through the little more like a T port that goes into the exhalation unidirectional valve. And one of the ways you can tell if the patient is taking a breath is this piece at the top, and you can actually see it'll kind of, when the patient takes a breath, it'll raise. So you can visibly see when that breath is taken. This is the pop-off valve. The pop-off valve allows the excess oxygen and inhalation anesthetic to exit the system. So when the patient exhales, you will see here on this little window, this little lever here will rise and fall with the breath, and it goes through the exhalation goes through the canister of the soda lime, and that absorbs the excess CO2. And then it exits, goes up through here, the pop-off valve, and then it goes through this scavenging tubing and exits the system through an active scavenging system. So it goes through this tubing here, and then our scavenging system is this pink line that is hooked up here next to the oxygen port. The pop-off valve can be set anywhere from fully open to fully closed. You can do it partially open. Here at Aves, we always leave it completely open. So we would close it off when we are giving a breath, when we squeeze the reservoir bag. And then as soon as we're done squeezing, we would release it so the excess gas can go into the scavenging system, and so the patient is not rebreathing that. Here we have the reservoir bag, and this bag is pretty much exactly like the name says. It is a reservoir of oxygen and the anesthetic gases. So we are able to monitor the patient's breathing by observing this opening and closing. We are also able to use this to give the animal a breath if we need to. With these reservoir bags, you do need to use a size that is appropriate for the patient. And we have like a size 0.5, and it goes all the way up to like, I think, a size 5 bag. And I think we even have larger than that here. But you definitely always want to make sure that it is the appropriate size bag for your patient. When the patient exhales and the carrier gas and the anesthetic go through this soda lime canister, that's where it absorbs the excess carbon dioxide, and then it sends that gas here through the pop-off valve through the scavenging system tubing. Okay, so what I'm going to go over now is the rebreathing system. This is what you call a universal F circuit. This size here, this pink tubing, is for patients under 7 kilograms. This larger tubing is for greater than 7 kilograms. So what this is this essentially is a tube within a tube. The inspiratory tube is this pink tubing on the inside. The expiratory tube is this clear tubing around it. So how this works is this is connected, the inspiratory valve here goes into the inspiratory unidirectional valve, and then you plug this F tubing into the expiratory unidirectional valve. And so what happens is the oxygen and the anesthetic gas comes through the system, the patient takes a breath out of here, and then when they exhale, it actually goes into this tubing, this outer tubing, and it comes back through here, goes through this Y tube here into the exhalation unidirectional valve, and then it goes through the Sotasorb canister, takes away the excess CO2, and then it goes through the scavenging tubing up through. This is the rest of the scavenging system that is plugged into the ceiling here, to an active scavenging system that expels the excess gases to the outside. Okay, so what I'm going to do today is do an anesthesia machine leak test. So what I have is my machine is hooked up to the oxygen system as well as the scavenging system, is this pink hose back here. I've got my rebreathing system. It's a pediatric unit connected to my anesthesia machine, as well as a 1 liter reservoir bag. So what I'm going to do is close my pop-off valve right here with my right hand. I'm going to occlude the tubing with my left hand, and I'm going to press the oxygen flush valve until my bag fills up and the manometer reads about 20 centimeters of water. And I'm going to watch to make sure that that needle does not drop more than 1 centimeter per second. If it drops faster than that, that means we have a leak. So I would need to check all of my tubing, reservoir bag. I'd need to check the seal on the soda lime canister, and go through all of the machine parts to look for the leak. But if it does not drop more than 1 centimeter per second, then that means that the system is in good working order. And this is very important. You need to do this before every procedure to make sure that the system is running optimally. So I'm going to step over here. I've occluded my tubing. I've got my finger closing the pop-off valve, and you can see here where I'm pressing, and I'm going to read my manometer. So I'm just going to duck down here. Okay, and you want to hold it for about 5 seconds. And as you can see, it dropped 1 centimeter in the entire time that I've been talking here. So that means that it has a good seal on everything. So this was a good leak test. So this machine is in good working order and ready to be used. Okay, so I'm going to discuss here the monitoring equipment. First thing is the pulse oximeter, and this is hooked up to a monitor. We are using the toe web, which is working very well. The SpO2 is 99, and it is the estimation of the saturation of hemoglobin. You can use the pinna of the ear, you can use the avulvar fold, the prepuce, toe web, the Achilles tendon, or any other area that is relatively hairless and thin. So a normal value is 95 to 100%. If it is 90 to 94, that is an indication of early hypoxemia. So checking to see, like maybe moving the probe to see if you can get a more accurate reading. 85 to 89 indicates that therapy is required. And then if it is below 84, that's a medical emergency, and you need to increase their oxygenation. Okay, so right now I'm going to talk about the blood pressure machine. So it consists of a cuff. It's got an internal sensor bladder, and then it's connected to the Cardell Veterinary monitor. So
when you're choosing the cuff size, you want the width of the cuff to be approximately 40% of the limb. So we have cuff size number 4 up on the forelimb there. But you can put it on the metatarsus, the metacarpus. You can put it on the proximal area to the carpus and the tarsus, and you can use the base of the tail. So a normal blood pressure for dogs and cats, systolic is about 110 to 160. Diastolic is 50 to 70, and then the mean is approximately 60 to 80. This measures all 3 of those. If the reading comes out to be outside those reference ranges, they should be reported to the doctor. Okay, so what I'm going to discuss now is monitoring for body temperature. You can either use a rectal probe or a thermometer. Today we're using the thermometer. Normal temp is between 97 and 100 degrees Fahrenheit. If the temperature is 89 to 93, that can prolong anesthetic recovery, and we would need to report to the doctor any temps above 103.5 and anything below 97. Okay. So this is my preceptor, Dr. Kim. So this is where I'm doing all of my anesthesia videoing, and so she has been with me when I intubated a couple weeks ago, and for all of the other procedures I've been working with Dr. Kim.
Hi. Okay.
Okay, so I'm going to place a cephalic catheter in this cat. First thing I'm going to do is shave the area. And we shave all the way around the arm. Alright, just get rid of the hair. And now I've got my scrub. I've got Chlorhex and alcohol. I'm going to start with the Chlorhex. Okay, I'm going to take my dry gauze, and I'm just drawing on the sides of the arm. I'm not drawing over the area where I'm putting in the catheter. Alright, so I'm going to use this 22 gauge catheter. I've got my primed T-port, and I've got another piece of dry gauze. I've got my tape here. I'll go over that as I'm going. Alright, so I'm going to go in, bevel up, at an angle. You can see the vein right there. You see the flash. There we go. Alright, so now I'm just anchoring down.
Are you looking at me?
Okay, I'm going to take my T-port. It is already flushed. Alright, I'm going to put my dry gauze underneath so when I take this out, if it bleeds a little, it won't get on my tape. And so now I'm going to flush the line to make sure that it's patent. Okay. Alright, I'm going to put this tape over the catheter hub here to help keep it in place. I'm going to put this piece on to help keep the T-port in. So I kind of wrap it around the hub like this. All right. tab on it so it's easy to take off later if we need be. All right, and that's how you put in a cephalic catheter. Good. Okay, so the catheter is in place, but I'm just placing a vet wrap over it just as a little bit of protection. You don't want to do it too tight. It's merely just a catheter guard. There you go. Okay, so I'm going to give the pre-medication to this cat, Sunny. It's going to be IM, and it is midazolam and buprenorphine. All right, so I'm going to pull the leg out here a little bit. I'm going to make sure that I don't go into the femur bone, so I'm going to go underneath it into this beefy part. Okay, and I'm going to draw back, make sure there's no blood. Okay, and that is how you give an IM pre-med injection. All right, so what we're doing now is we are going to induce anesthesia and intubate the patient. So we've got our oxygen on for pre-oxygenation. So I've chosen 2 ET tubes, a 4 and a 4.5. You can kind of anticipate the size by placing the end of the ET tube up between their nares. This fits perfectly, so this should be okay. I've got my lubricating jelly here. So the first thing I'm going to do is inflate my cuff, make sure there's no leaks and it inflates properly. Okay, and I'm going to roll this in some of the sterile lube. Going to deflate the cuff. Okay, so that's ready. I'm going to use my stylet kind of in place of a laryngoscope. Okay, so now I'm going to induce with the propofol. And we go pretty slow. You don't want to go too fast because it can induce apnea. We usually go about half of the way, so it'll be about 1.5 mils. And then I will test his reflexes and see if he's relaxed enough to intubate. So he's still got a little bit of a palpebral reflex. I'm just going to give a little bit more propofol. Pretty good? Okay, so now what I'm going to do is intubate. I've got my stylet and my ET tube. This will kind of help me. I'm going to pull the tongue away. And so I can see the push down on the epiglottis, and I can see right into the trachea. There we go. Okay, so now we are in. I'm going to pull my stylet out. I'm going to tie the tube in place. All right, we're connecting the oxygen. I'm going to inflate the tube cuff. And you can determine first we're going to check to see if the tube is in place by listening to the lungs while I give a breath. On both sides. Beautiful. Sounds good. And then we're also going to listen at the mouth to make sure we don't hear any air coming through. Okay, and I don't hear any air. And then to make sure that the cuff is not overinflated, I just kind of squeeze the pilot balloon a little bit. If it was really hard, I would need to take a little air out, but it seems to be just right. Okay, so that is how you induce anesthesia and intubate. Okay, so the patient is intubated, and now we're going to lubricate the eyes to keep them moist and prevent any scratches or ulcers.
So what I'm going to do now is palpate the bladder and express if necessary. And it feels pretty small, so we don't need to express. Okay, so for this video, I'm going to clip and clean this tumor. Okay, so now I'm using Chlorhex scrub and Chlorhex solution to do a rough scrub. We will do the sterile scrub when we get into the OR. I'm going to start at the center and work my way out in a circular motion. Being careful not to go over the old area. I don't want to contaminate my scrub pad. And when I reach the hair, that is considered dirty, so I need to start a new scrub pad. You want to do at least 3 passes with each the scrub and the solution. And this is what the site looks like. We have our margins here marked. This is a mast cell tumor, and this is clipping and cleaning. Can you grab that end and lift up? All right. There we go. Okay. That's how you transfer a patient to the surgery suite. Okay, so what I'm going to show you today is scrubbing in. So this is it's called Easy Scrub. It's a surgical scrub with a brush and a sponge. And it also has a nail cleaner on it. So I'm going to turn the water on, open my scrub pack, and the first thing I'm going to do is use the picker. So I'm going to go through and clean out from under all my fingernails. Now I'm going to take my scrub and I'm going to spend 10 seconds on each finger. 10 seconds on my palm, 10 seconds on the back of my hand, and then 10 seconds on this upper part of my arm, and 10 seconds on my lower part. And then I'm going to switch hands and do the same thing. Making sure never to drop my hand below my elbows. I'm going to move down my arm, 10 seconds. And I'm going to switch to my other hand. Okay, now I'm going to rinse. So dry, and then gown, and then glove. Alright, so I'm making sure my sterile towel does not touch my scrubs. Okay, next I'm going to put my gown on. I'm just going to lift it up out of the package and let it fall. I don't want to shake it. I'm going to slide my arms in.
flip it backwards. Okay. All right, so there, closed gloving on that hand. Then I'm gonna put this glove on top, just like that. Slide it on. Okay. All right. All right, so this is how you gown and close glove. What I'm going to do now is open the surgical pack. Okay, and put it on my sterile field.
Yeah. And then you can just.
So Dr. Kim placed the first tuck towel. I'm going to place the other ones, and then I'll do this side.
Put it on backwards. Over the body up there. Four quadrants.
On the bottom. Okay. Okay, so Ellen just handed me this sterile drape. So now I'm going to place it over.
Just like that. There you go. Shake it down. And you're gonna lay it over your sterile field.
Okay.
There you go.
And now Dr. Kim's gonna cut her surgery site. Okay, so I'm gonna blot the tissue for Dr. Kim. I thought I would forget, you know.
Avoid the mass section because you can see that there's some crusties on there as well. So I'm pretty sure there's bacteria. Medicine bombs and thumb forceps.
Medicine bomb. That.
And then some forceps.
Okay, so now what I'm going to do is load the scalpel blade. Alright, these are the needle holders. This is the scalpel handle. And I'm just going to kind of slide it onto this groove here. And it locks right into place. And then to hand it to Dr. Kim. Okay, so the blade is going to be facing away from me, and I'm going to pronate and hand it to her just like that. So some of the duties of a sterile technician are to accept sterile packs from the circulating nurse, responsible for passing instruments to the surgeon, maintaining the instrument table and making sure that everything is in working order, careful handling of the tissue in the surgery room is very important. For example, blotting blood so the surgeon can see the site better, or keeping the tissues moist. The sterile technician will also perform the instrument count and the sponge count. Sterile technicians are also sometimes involved in draping the patient. Sometimes they're involved in drug administration, such as a local anesthetic during the procedure, cutting sutures for the surgeon, and sometimes running the sutures while they're making a continuous pattern. As for not breaking sterility during the procedure, the sterile technician is not supposed to leave the sterile field. They should never turn their back on the field. They should always pass face to face or sterile to sterile. Scrubbed in personnel should not change positions, like from sitting to standing or standing to sitting. If sterility is broken, for example, if you drop an instrument, sometimes what we can do is flash sterilization. Other times it would be appropriate to just open a new clean instrument. If a glove is punctured, then the surgeon or the sterile technician would need to re-glove and possibly even re-scrub in and put new gloves on as well. So these are some of the duties of the sterile technician and how to maintain sterility, and then what to do if sterility is broken. Okay, for this video, this is a canine spay. She just finished draping and is now making the first incision.
Well, I broke down the ovarian ligament. I'm actually, so let's use the right wording, ovarian pedicle. And I'm going to tie the ovarian pedicle.
Okay, this is the uterine body, and what we're doing now is going to ligate the uterine body. Okay, so the spay is done, and now Dr. Kim is closing up the incision. Okay, so the canine spay is almost completely finished, and she's just finishing closing up the incision. Okay, so today I'm going to demonstrate cleaning the post-surgical suite. One very important aspect of it is cleaning every single horizontal surface. We will dispose of the waste in the kick bucket and all sharps in the sharps container. I'll kind of rotate the camera around so you can see these things. But I'm going to start here with the operating table. And the product that I'm using is called a cell. And this is a bactericidal cleaning agent. And this is what I will use to clean the entire surgery suite. And now I'm cleaning the base of the surgery table. So now what I'm going to do is clean the Mayo stand. So with the Mayo stand, I cleaned the top, the sides, and the base, all the way down to the wheels. It's very important to get all of the areas that can collect dust. Okay, and what I'm cleaning now is the table that contains all of our cardiac, esophageal monitor, the monitoring machine, and the shelves containing the equipment. We clean the esophageal monitor with alcohol. We use alcohol and some gauze pads. And just make sure that you get all around the knobs. And you clean all the way to the port. And for the capnograph monitor, I'll just clean it with the disinfectant. Now I'm just taking off the little baskets on the lower shelves and cleaning, making sure I get
Definitely all the horizontal surfaces, but also some of the vertical, any areas that will trap dust. Another thing we will do is clean the window ledge here. Okay. Another object that we clean is the extra surgical lamp. And again, it's just paper towels and disinfectant. And we clean the extension cord as well. Okay, next I'm going to clean the IV pole. I clean the machine and the pole. All the way down to the floor and the wheels. Make sure all the dust comes off. Okay, next step is to clean the counter here. So I'll just start over here. You're cleaning all the horizontal surfaces. I'm going to clean the X-ray holder. All of these little items can collect dust, so it's really important to make sure that you clean these as well. These blue cabinets here, I will wipe down these because these have horizontal ledges on them. Here you can see we have a suction unit cart, and I will take all of those items off and clean that as well. So the next step is I will be removing these mats here, both of these surgical mats. I'll be removing them and scrubbing them and letting them air dry. And my next step here is I'm going to vacuum the entire suite, and then I will clean it with the Swiffer. Last thing that I'm going to do is Swiffer. Okay, so now I'm in the pack prep area, and I'm going to show you how to clean instruments. Okay, so the first step is to put the instruments into, we put it in this container. It has distilled water in it, and this instrument cleaner. And we let it soak for about 5 to 10 minutes, and then we will scrub them to get whatever debris we can out of the joints and any blood in any of the grooves and the hemostats. Okay, so I've got my little toothbrush here, and I'm just going to kind of go over all of the instruments to make sure that there is no blood or tissue or anything on the instruments. So the next step after cleaning those is to use the ultrasonic cleaning machine. So what this is and I've already put some instruments in here, so I'm going to put all of the instruments in here. I'm going to, if they have box locks, I'm going to keep them open. This is distilled water, again with an ounce of the cleaner. And I will put the lid on, and then okay, after the sonic cleaner is done, I will pull out this tray, and I will place it on this towel here. Okay, so now what I'm going to do is separate all of the instruments and the instruments with hinges I will open up. So now that I have all my instruments laying out to dry,
This is the moisturizer that we put. I will spray it on all of the hinges. And then I will let this sit for 5 to 10 minutes. So now I've waited 10 minutes with the moisturizer on the hinges of all of the instruments. I've patted them dry just to get any excess off. So what I'm going to do now, I'm going to be putting together a dental extraction kit, and then I'm going to wrap some individual instruments over here. So what I'm going to use for the individual instruments are these smaller pouches, and for the curettes we just do 1 per pouch, and you just peel off the sticky end of the pouch here, and then you'll fold it back just like that. And then I'm going to put my initials and the date on here. Okay, for my dental extraction kit, I have several different types of hemostats. I've got tissue scissors. I've got molar extracting devices, and I've got a pair of forceps and a scalpel handle. And I'm going to place all of these into this larger pouch. All of the handled end items are going to go up here because the pack will be open from this direction, and that way all of the handles are ready to go. And I will be leaving the box locks open. And it will be folded down to secure the pouch. Okay, and again I will put my initials and the date and extraction kit. Just like that. So all the handled ends are up here where the pack will be opened after it is sterilized. And that is how you package a dental surgical extraction kit. Okay, so today I'm going to perform a surgical gown pack. So what you want to do is, this is the outside of your gown, and I'm going to go on the inside of my gown, and I'm going to take this armpit seam and the other armpit seam, and I'm going to fold these together, and I'm going to take the neck of the gown and I'm going to lay this down on my table. Just kind of unfold a little bit. So you want the outside of the gown, the sleeve, to be flat here. You're going to take the back of the gown and you're going to fold it so the seam is on the center fold of the front of the gown, and I'm going to kind of straighten it out here so it's flat along the armpit seam all the way down the side. And I'm going to pick it up very gently so I keep this fold, and I'm going to do the same thing on the other side. I'm going to kind of fold back the flap, straighten out the arm a little bit, and I'm going to fold the edge like this towards the center seam again. Okay. Then what I'm going to do is I'm going to take this armpit seam and I'm going to fold it into a quarter fold again towards the center
of the gown. I'm going to flip it over and do the same thing on the other side. Okay. And I want to keep my ties together here. So now that my gown is folded in quarters, and the inside of the gown is what is facing out. So I'm going to start from the bottom of the gown. I'm going to fold it in an accordion style. And you want the good rule of thumb is to make it about as long as your hand. And now that I've got this folded, here's the top of the gown. I'm just going to fold back the flap a little bit. I've got both of my neck ties here tucked in as well. Okay, so that is how you fold a gown. Then I'm going to take my huck towel. We always put, at this clinic, we put a huck towel in the pack with the gown, so the doctor has a sterile towel to dry their hands after the surgical scrubbing. So I'm going to take my towel and I'm going to quarter it, accordion style, long ways like that. And then I'm going to fold it into thirds, again, accordion style. And I'm going to fold back one of the flaps here, place it on top of my gown, and I'm going to take my steri strip and just tuck it in here. And next I will wrap it. Okay, so after I fold my gown and my huck towel and place my sterilization strip, this is how I'll know when it's unwrapped if it is sterilized. I'm going to take one of my wraps. So I've got it kind of like a diamond facing away from me. I'm going to take my gown just like this and place it in the center. I'm going to make my first fold over the top of the gown, and I'm going to fold the end down, and this is going to be a little tab that the doctor can pull. So what you want to do is you want to really keep this pretty tight, so I kind of scrunch it down a little bit. I'm going to take one of my sides, I'm going to tuck this in real tight and pull it over to that top part. Again, I'm going to make a little tab, folding down the corner. I'm going to keep it tight. Do the other side. Again, taking this corner and folding it back to make a little tab. And then last, I'm going to fold this end that's furthest away from me. I'm going to fold it tightly over the top of the gown, and then I'm going to tuck it in to the folds that I've already made and leave a little tab out like this. So I folded it over, tucked it in, and left a little tab out. Next is our second wrap. This is a new one. So what you're going to do is you're going to take your folded and wrapped gown pack and put it again in the center with the wrap in a diamond shape. I'm going to fold this corner up over the gown. And I'm going to fold it back to make the little tab. I'm going to go on the side, fold it up real tight, again making the tab. I'm going to take the opposite side, again over the top, making it very tight, and I'm going to fold back a little tab. And then last, take that opposite end, fold it over the top real tight. I'm going to flip it around, and I'm going to tuck it in just like I did on the first pack. So it's this exact same method for the first wrap and the second. So here I have my double wrapped gown and huck towel with the little tab to pull out to open the pack. Next, the gown I used is an extra large non-cloth gown. So I'm going to take my masking tape. I'm going to put it on the top of the pack like that. And I'm going to write on here extra large non-cloth gown. So it looks just like that. Then I'm going to take my sterilization strips, and this is a type of masking tape. It's got little horizontal lines on here, and when it's sterilized, those lines turn black. So what I'm going to do is I'm going to put 2 pieces on here. Doesn't need to be too long. And I'm going to put it on the ends here, keeping the pack closed. I'll show you. Okay. So I put it on here just like that with the tabby sticking out. And I'm going to initial and date these strips. Okay, so you can see here my initials and the date. So this is how you properly pack a surgical gown with a huck towel.
Okay, so the principles that the autoclave works is, so how the machine works is steam will penetrate the packs, and as they penetrate the entire pack, they then become sterile. It has a certain temperature for a certain length of time, and it is different whether you're doing packs or wrapped gown packs like I had set up earlier and had on the video. So the steps in using them. Okay, so when you want to pack an autoclave, it's got a couple different shelves here. And we usually put larger stuff down at the bottom. The main thing is you don't want to overpack it because you want the steam to go evenly all throughout the machine. So I've got all of the items here on all of the shelves. So the next step is to make sure that the machine is going to work properly. You're going to look at this distilled water tube. The line is up to here, and you want it in that green line. If it is below, you need to put some distilled water in here and fill it up. So the next step is just to close the autoclave. Okay. And the way this one works, it's all preset. So what I'm doing here is I am doing pouches. So I will just push the button here. It says 270 degrees Fahrenheit for 5 minutes. So then I'm going to push start. If I were to do any of these other buttons, it would have different temperatures and duration. So this is another type of autoclave that we have. This is the one I just packed, and this is just an older version. But to maintain the autoclaves, they are cleaned daily just by wiping down the outside with a wet cloth, but we clean them monthly. So what we would do is we remove the trays. We would take this cleaner and its powder, and we would sprinkle it along the bottom here, and then we would close it and run a cycle. That's how you maintain an autoclave. So different ways to ensure that the items have been sterilized are these here on the paper pouches. These arrows here that are in pink will change to black when the package is sterilized. And if we use these little steam strips, then you can kind of see it has a K and an arrow, and that will turn black when it has been sterilized.